Your mood right now might not be what you think it is. Not in the psychological sense, not in the way your therapist would frame it, but in a purely biochemical sense that most mental health professionals never investigate. What feels like anxiety, like that constant low-level dread that sits in your chest, or what presents as depression, that profound fatigue and inability to feel pleasure, might actually be your brain struggling to produce the neurotransmitters it needs because it's missing specific raw materials. We're talking about nutrient deficiencies, and the mental health symptoms they create are clinically indistinguishable from primary psychiatric disorders. The problem is that in modern medicine, when someone presents with anxiety or depression, the default pathway is psychiatric medication, not metabolic investigation. Nobody runs a comprehensive nutrient panel. Nobody asks about diet in any meaningful detail. And as a result, millions of people are being treated for mood disorders when what they actually have is a deficiency state that could be corrected with targeted nutrition. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years working in accident and emergency, I've seen patients present with severe anxiety attacks, profound depression, and even psychosis that turned out to have completely reversible nutritional causes. I've seen people on multiple psychiatric medications for years whose symptoms resolved when we identified and corrected a single vitamin deficiency. My goal now is to help people understand that mental health and metabolic health are not separate systems. They're deeply interconnected, and sometimes what looks like a broken mind is actually just a malnourished brain. For the next several minutes, I'm going to walk you through 10 specific nutrient deficiencies that can create symptoms identical to anxiety and depression, explain the mechanisms behind each one, and tell you what to do if you suspect you might be affected. If you're watching this video, you're probably struggling with mood symptoms yourself, or you're trying to help someone you care about who is. I want to make you a promise right now. I promise to keep creating the most scientifically grounded, clinically useful content I possibly can to help you understand the connection between nutrition and mental health. All I ask in return is that you give this channel a chance and hit the subscribe button. If you get to the end of this video and you don't think it was worth your time, or you haven't learned something that could genuinely change how you approach mental health, then feel free to unsubscribe. No hard feelings. But if you give me your time and attention, I'll give you everything I've learned from over a decade in medicine about the metabolic foundations of mood and cognition. Please help me out. Hit the subscribe button to help this channel reach more people like you, and let's continue. Before we get into specific deficiencies, we need to understand what anxiety and depression actually are at a neurochemical level, because once you see the biology, the connection to nutrition becomes obvious. Anxiety, in its most reductionist form, is excessive activity in the brain's threat detection and stress response systems. It involves dysregulation of neurotransmitters like serotonin, gamma-aminobutyric acid, which is known as GABA, and norepinephrine. Depression, similarly, involves reduced activity in reward and motivation circuits, driven primarily by deficiencies or dysfunction in serotonin, dopamine, and norepinephrine. What most people don't realize is that every single one of these neurotransmitters is synthesized from amino acids, vitamins, and minerals that you get from food. Serotonin is made from the amino acid tryptophan, but it requires vitamin B6, folate, and magnesium as cofactors in the synthesis pathway. Dopamine is made from the amino acid tyrosine, and it requires iron, vitamin B6, folate, and vitamin C to be produced properly. GBA is synthesized from glutamate, using vitamin B6 as an essential cofactor. When any of these nutrients are deficient, the brain simply cannot produce adequate amounts of the neurotransmitters needed for stable mood and appropriate stress responses. What you end up with is a brain that's neurochemically depleted, and the symptoms that emerge are indistinguishable from primary psychiatric illness. The first deficiency we need to discuss is vitamin B12, and this is one of the most commonly missed diagnoses in mental health settings. Vitamin B12 is essential for the synthesis of serotonin, dopamine, and other monoamine neurotransmitters. It's also critical for maintaining the myelin sheath that insulates nerve fibers and allows them to transmit signals efficiently. When B12 levels drop even into the low normal range, people develop profound fatigue, cognitive fog, irritability, and depression that can be severe. Some patients develop anxiety, particularly related to obsessive thoughts or compulsive behaviors. The mechanism involves impaired methylation, which is a biochemical process that's essential for neurotransmitter synthesis and for clearing homocysteine, an amino acid that becomes neurotoxic when it accumulates. Elevated homocysteine levels damage blood vessels in the brain and interfere with neurotransmitter metabolism, creating a vicious cycle. The groups most at risk for B12 deficiency include people over 50, because stomach acid production declines with age and you need stomach acid to absorb B12. Vegetarians and vegans, because B12 is found almost exclusively in animal products. People taking proton pump inhibitors or metformin, both of which interfere with B12 absorption. And people with autoimmune conditions like pernicious anemia or inflammatory bowel disease that damage the gut lining. The standard reference range for B12 on blood tests is quite broad, and many people have symptoms at levels that are technically normal but functionally inadequate. Optimal B12 levels for neurological and psychiatric health are generally considered to be above 400 picomoles per litre, not just above the lower limit of normal. The second deficiency is vitamin D, and while most people know that vitamin D is important for bone health, very few understand its role in brain function. Vitamin D receptors are densely concentrated in areas of the brain involved in mood regulation, including the hippocampus and prefrontal cortex. Vitamin D modulates the synthesis of serotonin and dopamine, and it has direct anti-inflammatory effects in the brain. When vitamin D levels are low, which is extremely common in northern latitudes, in people who avoid sun exposure, and in people with darker skin living far from the equator, the risk of both depression and anxiety increases significantly. Multiple large observational studies have shown strong correlations between low vitamin D status and increased rates of major depressive disorder, and several randomized controlled trials have shown that vitamin D supplementation improves mood symptoms in people who are deficient. The mechanism involves both direct effects on neurotransmitter synthesis and indirect effects through reducing neuroinflammation. Chronic inflammation in the brain interferes with serotonin metabolism and increases the production of anxiety-promoting neurotransmitters. Vitamin D, by reducing inflammatory signaling, helps restore normal neurotransmitter balance. The challenge with vitamin D is that dietary sources are limited. Sun exposure is variable depending on where you live and your lifestyle, and deficiency is incredibly common. Blood levels should ideally be above 75 nanomoles per litre for optimal mood and cognitive function, but many people run levels well below 50 without realizing it. The third deficiency is magnesium, and this is perhaps the most underappreciated nutrient in mental health. Magnesium is involved in over 300 enzymatic reactions in the body, including the synthesis of serotonin and GABA, the regulation of the hypothalamic pituitary adrenal axis, which controls stress responses, and the modulation of N-methyl D-aspartate receptors in the brain, which are involved in excitatory neurotransmission. When magnesium levels are low, the brain becomes hyperexcitable, neurons fire more easily, stress responses are exaggerated, and anxiety symptoms intensify. People with magnesium deficiency often describe feeling wired, unable to relax, irritable, and prone to panic attacks or generalized anxiety. Sleep is typically disrupted because magnesium is required for the production of melatonin and for the activation of the parasympathetic nervous system that allows the body to shift into rest and recovery mode. The problem is that magnesium deficiency is extremely common and difficult to detect with standard blood tests. Serum magnesium levels only reflect about 1% of total body magnesium, most of which is stored intracellularly. You can have normal serum magnesium and still be functionally deficient at the tissue level. Magnesium is depleted by chronic stress, by high sugar intake, by alcohol consumption, and by certain medications, including diuretics and proton pump inhibitors. The best dietary sources are leafy green vegetables, nuts, seeds, and whole grains, but modern diets are often deficient, and soil depletion has reduced the magnesium content of many foods. The fourth deficiency involves the B vitamins, particularly B6, folate, and B9, which work together in what are called methylation pathways. These pathways are essential for producing serotonin, dopamine, norepinephrine, and for clearing homocysteine from the bloodstream. When any of these B vitamins are deficient, methylation becomes impaired, neurotransmitter synthesis drops, and homocysteine accumulates. High homocysteine levels are associated with increased anxiety, depression, and cognitive decline. Vitamin B6 specifically is required for the conversion of tryptophan to serotonin and for the synthesis of GABA from glutamate. Without adequate B6, the brain cannot produce sufficient amounts of these calming neurotransmitters, and anxiety becomes more prominent. Folate is required for the synthesis of tetrahydrobiopterin, which is a cofactor needed to produce serotonin, dopamine, and norepinephrine. Folate deficiency leads to reduced neurotransmitter production across the board and creates symptoms of both depression and anxiety. What complicates this further is that many people have genetic variations in the enzymes that process folate, particularly a variant in the MTHFR gene that reduces the efficiency of folate metabolism. People with these variants need higher folate intake to maintain normal neurotransmitter function, and they may benefit from taking methylfolate, which is the active form that bypasses the impaired enzyme. The standard dietary sources of B vitamins include leafy greens, legumes, whole grains, eggs, and meat, but deficiencies are common, particularly in people who eat highly processed diets or who have digestive issues that impair nutrient absorption. The fifth deficiency is iron, and this affects mood through several mechanisms. Iron is required for the synthesis of dopamine, norepinephrine, and serotonin. It's also essential for oxygen transport in the blood and for mitochondrial energy production. When iron levels drop even into the low normal range, people develop profound fatigue, which is one of the hallmark symptoms of depression. They lose motivation, struggle to concentrate, and experience what's called anhedonia, which is the inability to feel pleasure. These are core features of major depressive disorder, and they can be entirely caused by iron deficiency without any underlying psychiatric pathology. Iron deficiency is particularly common in menstruating women, in vegetarians and vegans, because plant-based iron is less bioavailable than heme iron from animal products, and in people with digestive conditions that impair absorption. The challenge with iron is that standard blood tests often focus on hemoglobin and hematocrit, which only drop once iron stores are severely depleted. Ferritin, which measures stored iron, is a better marker of iron status, and optimal levels for cognitive and mood function are generally considered to be above 50 micrograms per litre, not just above the lower limit of normal. Low ferritin without anemia is incredibly common and often goes unrecognized, leaving people to struggle with depression and fatigue that's entirely reversible with iron supplementation. The sixth deficiency is zinc, which is involved in the regulation of neurotransmitter systems, the modulation of the stress response, and the maintenance of neuroplasticity. Zinc is a cofactor for enzymes that synthesize GABA, and it modulates the activity of glutamate receptors in the brain. When zinc is deficient, the balance between excitatory and inhibitory neurotransmission shifts, and anxiety symptoms become more pronounced. Zinc also has anti-inflammatory properties and supports immune function, which indirectly affects mood because chronic inflammation drives depression. Multiple studies have shown that people with depression have lower zinc levels than healthy controls, and several clinical trials have demonstrated that zinc supplementation improves response to antidepressant medication. Zinc deficiency is common in people who eat low amounts of meat and seafood, in people with digestive disorders, and in people with chronic stress or high alcohol intake, both of which deplete zinc. The best dietary sources are oysters, red meat, poultry, beans, nuts, and whole grains. Blood levels of zinc are not always reliable because zinc is stored intracellularly, but symptoms of deficiency include poor immune function, slow wound healing, hair loss, and mood disturbances, all of which can point toward inadequate zinc status. The seventh deficiency is omega-3 fatty acids, particularly eicosapentaenoic acid, known as EPA, and docosahexaenoic acid, known as DHA. These are structural components of neuronal membranes, and they're involved in the regulation of inflammation, the modulation of neurotransmitter signaling, and the maintenance of synaptic plasticity. When omega-3 intake is low, which is extremely common in Western diets that are high in omega-6 fatty acids from vegetable oils and low in fish consumption, the brain becomes more inflamed and less responsive to serotonin and dopamine signaling. This creates symptoms of both depression and anxiety. Multiple meta-analyses of randomized controlled trials have shown that omega-3 supplementation, particularly with EPA, improves symptoms of major depressive disorder. The doses that seem to be effective are relatively high, typically 1 to 2 grams of EPA per day, which is difficult to achieve through diet alone, unless you're eating fatty fish multiple times per week. The mechanism involves reducing neuroinflammation, improving neuronal membrane fluidity, and enhancing the responsiveness of neurotransmitter receptors. Omega-3 status can be assessed with blood tests that measure the omega-3 index, which is the percentage of red blood cell membranes composed of EPA and DHA, An optimal index for mental health is generally considered to be above 8%, but many people run levels well below that. The eighth deficiency is iodine, which is essential for thyroid hormone production, and thyroid function is intimately connected to mood regulation. Even subclinical hypothyroidism, where thyroid hormone levels are at the low end of normal but not yet low enough to be classified as disease, is associated with increased rates of depression, anxiety, and cognitive impairment. Iodine deficiency is the most common cause of hypothyroidism globally, and while iodized salt has reduced severe deficiency in many countries, marginal deficiency is still common, particularly in people who avoid iodized salt, who eat low amounts of seafood and dairy, and who consume large amounts of goitrogenic foods, like raw cruciferous vegetables, that interfere with iodine uptake. The symptoms of iodine deficiency overlap almost completely with depression, including fatigue, weight gain, cold intolerance, and mental sluggishness. Correcting iodine deficiency through supplementation or dietary changes can dramatically improve mood and energy levels, but it needs to be done carefully because excessive iodine can also cause thyroid dysfunction. The optimal approach is to assess thyroid function with blood tests that include thyroid-stimulating hormone, free T4, and free T3, and to evaluate iodine status through urinary iodine excretion if deficiency is suspected. The ninth deficiency is amino acids, particularly tryptophan and tyrosine, which are the precursors to serotonin and dopamine respectively. While these are not vitamins or minerals, they are essential nutrients that must be obtained from dietary protein, and deficiencies can occur in people who eat very low protein diets, who have impaired digestion and absorption of protein, or who have increased demands due to chronic stress or illness. Tryptophan is converted to serotonin in the brain, but it competes with other amino acids for transport across the blood-brain barrier. When protein intake is low, or when the diet is very high in carbohydrates, tryptophan availability in the brain decreases and serotonin synthesis drops. This can create or worsen depression. Tyrosine is converted to dopamine and norepinephrine, and deficiency leads to reduced motivation, poor concentration, and fatigue. Some people, particularly those with chronic stress or high cognitive demands, may benefit from direct supplementation with these amino acids. But the foundational approach is ensuring adequate high-quality protein intake from sources like meat, fish, eggs, dairy, legumes, and soy. The 10th deficiency is choline, which is a nutrient that most people have never heard of, but which is essential for brain health and mood regulation. Choline is required for the synthesis of acetylcholine, a neurotransmitter involved in memory, attention, and mood. It's also a precursor to phosphatidylcholine, which is a structural component of cell membranes and is particularly important in the brain. Low choline intake is associated with increased anxiety and mood disturbances, and some research suggests that choline supplementation can improve symptoms in people with anxiety disorders. Choline is found in eggs, liver, fish, and some plant foods, but many people don't consume adequate amounts, particularly if they avoid eggs and organ meats. The recommended intake is around 400 to 500 milligrams per day, but optimal levels for mental health may be higher. In emergency medicine, we occasionally see extreme cases of nutrient deficiency presenting as acute psychiatric crises. I've seen patients with severe B12 deficiency who developed psychosis that resolved completely with B12 injections. I've seen people with profound magnesium deficiency presenting with panic attacks so severe they thought they were having heart attacks. I've seen patients on psychiatric wards for weeks whose depression lifted when someone finally checked their thyroid function and corrected their iodine deficiency. What these cases taught me is that mental health symptoms are not always primarily psychiatric. Sometimes they're metabolic, and the treatment isn't therapy or medication, it's nutrition. The challenge is that the medical system is not set up to investigate this systematically. When someone presents with anxiety or depression, the pathway is assessment, diagnosis, and prescription. Nobody runs a comprehensive nutrient panel that includes B12, folate, vitamin D, magnesium, iron, zinc, omega-3 status, and thyroid function unless there's a specific reason to suspect deficiency. And as a result, countless people are being treated with psychiatric medications that may help symptomatically but don't address the underlying cause. The answer to whether you have a nutrient deficiency causing your mood symptoms is not something you can determine on your own without testing. The symptoms overlap too much with primary psychiatric conditions to distinguish them clinically. What you can do is work with a physician who understands the connection between nutrition and mental health and who is willing to run comprehensive testing. That means checking serum B12 and methylmalonic acid if B12 deficiency is suspected, checking vitamin D levels, checking magnesium through red blood cell magnesium rather than serum magnesium if possible, checking ferritin and iron studies, checking zinc, checking thyroid function comprehensively, and potentially checking omega-3 status through an omega-3 index test. If deficiencies are identified, targeted supplementation or dietary changes can be implemented, and in many cases, mood symptoms improve significantly within weeks to months. The key is using the right doses and the right forms of nutrients, because not all supplements are created equal, and some forms are absorbed and utilized far better than others. What's critical to understand is that correcting nutrient deficiencies doesn't mean abandoning other mental health treatments. If you're on medication that's helping you, you shouldn't stop it without medical supervision. If you're benefiting from therapy, that should continue, but addressing nutritional deficiencies can enhance the effectiveness of those treatments, and in some cases allow for lower medication doses or even complete resolution of symptoms. Mental health is multifactorial, and nutrition is one of the most modifiable factors we have. The patients who do best are the ones who address mood from multiple angles, including psychological, social, and metabolic. Nutrition is the metabolic foundation, and when it's solid, everything else works better. So where does this leave us? 10 nutrient deficiencies that can mimic anxiety and depression. Vitamin B12, vitamin D, magnesium, the B vitamin complex, particularly B6 and folate, iron, zinc, omega-3 fatty acids, iodine, amino acids, and choline. Each one affects neurotransmitter synthesis, neuronal function, or brain inflammation in ways that create symptoms indistinguishable from primary psychiatric illness. The prevalence of these deficiencies is higher than most people realize, and they're rarely investigated in standard psychiatric care. What actually resolves these symptoms is identifying the specific deficiencies through comprehensive testing and correcting them with targeted nutrition, whether through diet, supplementation, or both. This isn't about replacing psychiatric care with nutrition. It's about recognizing that sometimes what looks like a broken mind is actually just a malnourished brain, and the treatment is fundamentally different. If you're struggling with anxiety or depression, particularly if you haven't responded well to standard treatments, investigating your nutritional status is not alternative medicine. It's good medicine, and it might be the missing piece you've been searching for. Finally, if you found this information valuable and you think it could help others who are struggling with mood symptoms, please subscribe to the channel. Every subscription helps this content reach more people who need to understand the connection between nutrition and mental health. And I'm committed to continuing to provide scientifically grounded information that you can actually use to improve your health. Thank you for watching.